Did you know that 5 to 10% of the general population have a lifetime prevalence of developing peptic ulcer disease? And this actually has a 10 to 20% risk of complications that can actually be deadly. How does it present? Well, you may have had epigastric pain, early satiety, or sometimes pain relieved with an antacid like Tums. In this video, we're actually going to talk about what causes peptic ulcer disease, how to diagnose it, understand the pathophysiology so that we can provide the right treatment, and we're going to give you the most up-to-date results. Join me in this video to find out how to manage peptic ulcer disease. Before we dive in to discuss the details on peptic ulcer disease, let's actually understand the stomach. The stomach has several parts. From the esophagus, as it enters, it starts with the cardia, which is present with multiple mucus-producing cells. And as you go down towards the body and the antrum, there is actually now more acid-producing cells. And we know as you go towards the pylorus, which acts as a valve to control the chyme that goes into the duodenum. So let's look at the type of ulcers based on location. If you look at diagram A, it actually shows the more distal an ulcer towards the body of the stomach, it is more related to acid hypersecretion, because these are the locations where there are going to be cells responsive to gastrin and acid production. The more proximal, the less it is related to any acid hypersecretion. Most likely, this would be a mucosal barrier issue, such as those related with smoking, or H. pylori, or NSAIDs. So, there are actually various causes of peptic ulcer disease, but the top two are going to be your H. pylori infection and your NSAIDs. Both actually affect the mucosal barrier, with H. pylori having a urease that degrades the urea, protecting it from the acid of the stomach, and as it multiplies, it actually starts destroying the stomach, causing gastritis and eventually ulcer disease. For NSAIDs, they work as a COX-1 inhibitor. And what does this do? Well, when it affects the mucosal barrier of the stomach, it then allows the stomach acid to start degrading the stomach because the mucosal barrier has been compromised. And in that way causes gastritis, and the cascade continues. Other things which are related to peptic ulcer disease are smoking, alcohol use, stress, and if you're unlucky, you could actually have a form of condition where you have a tumor with a hypersecretion of the acid called gastrinoma or Zollinger-Ellison syndrome. Most of those that have been mentioned after actually are regarding acid hypersecretion. So, now that we actually talked about the causes and the pathophysiology of how the disease process occur, we have to know how to diagnose it. And the gold standard would be endoscopy, which will either show gastritis or ulcer formation, and biopsy, that histology can be performed so that they can look at it under a slide and determine what type of inflammatory reaction there is and what is the cause. But should every patient undergo an endoscopy? Well, this is going to be a clinical judgment. Most of the time, patients are treated empirically with antacid between 4 to 8 weeks. And in a select group of patients, early endoscopy may be warranted. Who are they? Those who have warning signs, because some patients may present with signs of cachexia, severe malnutrition, weight loss, or concerning signs of malignancy. In those instances, it may be more prudent to actually do early endoscopy to ensure that there is early diagnosis of any morbid disease such as cancer. Other things to consider on a workup is testing for H. pylori. And this could be done with endoscopy and biopsy, but for people who do not undergo endoscopy, there are several things that you can do. One is going to be a urea breath test, a stool antigen, a serum antigen, and as I mentioned, endoscopy with biopsy. But how do I differentiate on what to use when? First of all, urea breath test is something that confirms active infection. Same thing with stool antigen. Both are a little bit more cumbersome to do. Whenever you are having any treatment failures, say you had somebody with H. pylori that was previously treated and they have persistent gastritis, the best thing to do is actually do a biopsy so that they can confirm the active presence of that bacteria, and then they can perform culture and sensitivities. So there's going to be 4 complications of peptic ulcer disease. And the first and most common one is actually hemorrhage, when you're bleeding. And this has a mortality of up to 8.6%. The first line would be endoscopy. But before we go to endoscopy, we have to know our A, B, C, D, E. What are they? Protect the airway, because you don't want to aspirate blood and then have more problems. Breathing, circulation. Make sure you have IV access and start resuscitating with either fluids and blood if needed. And the fourth one is going to be their drugs. You got to start them on some PPI. And recommendations, although it's debated, most people recommend starting a bolus and followed by a continuous infusion up to 72 hours. Lastly, you then perform endoscopy. When you do endoscopy, you're looking for the bleeding, and we have the force classification to look at active bleeding, signs of recent hemorrhage, and lesions without active bleeding. From there, you can actually look at the risk of rebleeding and figure out which treatment you want to perform. This could be either epinephrine injection, cautery, or clipping. What is your second line? It's going to be angiography if available, followed by surgery as your last resort. The second complication of peptic ulcer disease is actually perforation. And this is the most common indication for surgery and has a mortality of 3 times compared to bleeding, which is up to 23%. Does everybody need to undergo surgery? Well, you have to be selective on those people who you are going to treat non-operatively. They have to be stable and have a contained perforation with no signs of peritonitis. You can perform an upper GI, and if there is no active leak and everything's contained, you can monitor them and see if they will progress. However, for patients who are septic, peritonitic, with free extravasation, then they should undergo surgery. And surgery will be dictated depending on the size and location of the perforation. This could be either just a primary closure with patch repair or a formal resection, including a anti-ulcer or acid-reducing procedure, which is a vagotomy. We have several pictures of types of reconstruction after a resection, which includes a Billroth 1, which is a gastroduodenostomy, a Billroth 2, a gastrojejunostomy, and a Roux-en-Y reconstruction. If you look at the ratio, bleeding is 6 times more common than perforation, but perforation has a higher mortality and is a surgical emergency. The third type of complication of peptic ulcer disease is obstruction, and this occurs most commonly on a type 2 ulcer. When you have a obstruction around the pylorus, then you either have to do a resection followed by a reconstruction, which I had mentioned from above. The fourth one is actually malignancy, because with chronic gastritis and multiple insults to the stomach, this can cause transformation into a malignancy, which can be either adenocarcinoma or hematoma from H. pylori infection. And depending on the treatment, you have to have a histologic diagnosis to appropriately stage them and treat them properly with either chemotherapy or surgery plus minus chemotherapy. Whenever you're managing peptic ulcer disease as part of your diagnosis, the most important things that you have to look for are the warning signs. Do they have a history of bleeding, perforation, obstruction, or concerns of malignancy? Once you've ruled that out, then you can start screening for its causes. Do they have a history of H. pylori, previous diagnosis? Are they smoking, alcohol abuse, or NSAIDs? These are the things that you should be asking, and then from there, if they don't have any of those, then you can treat them with a low-dose PPI for 4 to 8 weeks and monitor their signs of response after completion of the treatment. for those who are refractory, considering further workup with endoscopy or testing for H. pylori is of importance. So for treatment of H. pylori, it actually started with triple therapy before, in which you had a PPI plus a combination of two antibiotics. There were choices between amoxicillin, clarithromycin, tetracycline, and metronidazole. A mnemonic that I use is AC, TC, MC, TM. But now this has actually changed from triple therapy to quadruple therapy, and the addition of bismuth was performed. And there is going to be first line, which is mostly amoxicillin and clarithromycin. But as the incidence of H. pylori has been increasing, with up to 30 to 40% of the US population affected, then there is going to be resistance to those four drugs. And so the most recent changes are actually utilizing other drugs, which include rifabutin and vonoprazan. And this table basically shows you a different type of therapy that is now being recommended. Now that we've actually summarized and talked about how to diagnose it, what are the causes, and what are the modes of treatment, understanding when to intervene when it's actually urgent. I hope you guys liked the video. Please click the like and subscribe button and check out the videos above for more learning. And if you have any questions or comments, please type them in the chat below, and I'll see you guys next time.